Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. And today we're going to talk about this very interesting and important concept called holistic approach to the management of diabetes. I've got several videos on different aspects of diabetes, but this you can take as a summary covering all components of diabetes which we need to cover, which we need to treat so that patient can have a comfortable life without morbidity and without mortality. Translate into practice. So these four alphabets A, B, C, D of course can be easily remembered, and A stands for A1C. A is derived from A is derived from HbA1c, and that means glucose control. And this HbA1c should be individualized. As far as ADA guidelines are concerned, for majority less than 7, but in some individuals you should achieve better one. And blood pressure, again, individualized, because the blood pressure which may be considered acceptable in a non-diabetic may be considered high in individual with diabetes. Now the third component of this alphabet approach is cholesterol. In cholesterol, we have many agents available. Let's first talk about the goal. Now in normal individuals, if we read the report of cholesterol, LDL of less than 130 is considered okay. But in patient with diabetes, I think the ideal LDL should be less than 70, especially if they have long-standing history of diabetes. In relatively short history of diabetes, maybe 100 is also okay, but 130 is of course very high. So I think depending upon your patient, if patient has got long-standing history of diabetes, then you should try to get their LDL to below 70 milligram per deciliter. And if they already have atherosclerotic cardiovascular disease, because it is common complication of diabetes, then the goal is less than 55 milligram per deciliter. Yes, you heard it right, 55 milligram per deciliter. That is very idealistic goal, but achievable in many patients because we have very strong tools available now. Of course, some people, so the best treatment is atorvastatin 20 milligram or a rosuvastatin 10 milligram. This is medium intensity statins. I think they should be started. Of course, we have other statins also, but I have included the most commonly prescribed 20 milligram of atorvastatin or a 10 milligram of rosuvastatin. Either of the two is acceptable. So then you monitor their lipids and see if their LDL is below the goal, then of course 70 or below, then that dose may be continued. The problem with rosuvastatin and atorvastatin is its tolerability. Some individuals, they develop myalgias. Very rarely, some individuals may also develop rhabdomyolysis. That of course is a serious complication, but myalgia is fairly common. If somebody develops myalgia, I think first thing you should do is to try to reassure the patient. Maybe you can try to adjust the dosage a bit. If myalgia is unacceptable, intolerable, then of course we can't keep pushing with these drugs. Then we have the alternatives also. Alternatives are ezetimibe. Ezetimibe is a very interesting drug. It prevents absorption of cholesterol from the intestine. So if taken with meal, it will prevent absorption of cholesterol which is taken with meal, plus the cholesterol which is secreted by the liver. Liver also secretes a lot of cholesterol into the intestine, which is then absorbed. So ezetimibe actually have very strong effect if taken with meal. So it will prevent absorption of total cholesterol coming from the diet and also coming from the liver. And this is usually combined with atorvastatin, rosuvastatin in low dose. Or the other option is bempedoic acid, which is a new drug, and this is also fairly effective. This does not have the typical side effect associated with statins, but it is not a primary lipid-lowering drug. Those patients who do not tolerate these statins, they can be given bempedoic acid. And bempedoic acid as well as statins, they can be combined with ezetimibe. And they all three can also be combined. So for those who fail to achieve their goal, but they're tolerating statins, then we can give them 2 or 3 drug combination. Then for some individuals, those who do not tolerate statins, but these 2 drugs are relatively milder as compared to statins, for them we have 2 more potent drugs, PCSK9 inhibitors. These are in the form of injections, and then this small interfering RNA, this is inclisiran, this is available in our country. So either of the 2 can be used, but they are in the form of injection and very, very expensive. And our local experiences so far limited because of their expense, they're not used frequently. But they can be combined with statins also. All these drugs, the statins and bempedoic acid and the PCSK9 inhibitors, they all block that chain of sequence which ultimately lead to the production of cholesterol. So we have various tools. Use rational combination, rational dosage to keep their LDL below 70 milligram per deciliter. Or the individual goal, those patients who have atherosclerotic cardiovascular disease, for them the goal is 55. So this is the part 2. We have covered in a 3. We have covered A1C, we have covered blood pressure, and we have also now covered cholesterol. But C also stands for cessation of smoking. Smoking is extremely common in our country also and contribute to the atherosclerotic cardiovascular disease in diabetic individuals. So I think the problem is very rarely patient would come to you for counseling about cessation of smoking. They would come for their diabetes or for their hypertension. But during interview, when you find out that they smoke also, then I think you should talk about it a bit at least. You should make them aware that this is as big an issue as diabetes or hypertension and high cholesterol. So you're spending so much money and doing so much effort to control other components, and you should not allow your body to end up in complication by smoking. And if patient is convinced, then I think patient may decide to quit at the same time. But of course, if patient does not make up his mind, then he or she should be encouraged to set a date when they're going to try it. It should be complete cessation of all types of tobaccos and vaping, and it should be permanent to have full benefits. And I think again, using your relationship with the patient and highlighting the importance of smoking, you can convince the patient, you can counsel the patient that cessation of smoking is going to be very, very rewarding. Although it is going to take a lot of effort, and for a brief period patient will go through some withdrawal effects, but there are many aids available. The best, of course, thing which works is the willpower. So if you highlight it well, then I think patient will be willing to quit smoking. Thank you very much for your patient listening, and I would request you to join my other videos also. This has been Professor Aziz Rehman for Medurstand-Understanding Medicine.